The unresolving diplopia, Part 2. In this particular patient, the limitation of elevation in adduction and the hypotropia can be explained by injury to the inferior oblique muscle. The inferior oblique, being closer to the orbital floor than the inferior rectus muscle, can be easily injured, either by the fracture itself or during attempts of repairing the fracture. The signs which are in favor of the inferior oblique injury: the positive head tilt, and an A pattern exotropia. The other possible explanation for the limitation of elevation in adduction is a traumatic Brown syndrome. This can be caused by an indirect injury to the trochlea following trauma from down and out. The clinical signs which are in favor of a Brown syndrome included the marked limitation of elevation in adduction and the significant exotropia in the primary position. Forced adduction test was done and showed that the left superior oblique muscle was slightly tighter than normal, but not as tight as you would expect in a Brown syndrome. A left superior oblique tenotomy was done with a 6 mm suture spacer in order to weaken the left superior oblique muscle. Following surgery, the patient had some improvement, but still there was residual exotropia and hypertropia, and residual limitation of elevation in adduction, together with some residual intorsion of the left eye. So what will be your next step? We are honored to have with us Professor Dr. Ibrahim EL-Adawy and Professor Dr. Hajjo to comment on this case.
Bismillah ar-Rahman ar-Rahim. I am Ibrahim EL-Adawy, Professor of Ophthalmology, Mansoura University. First, I would like to thank Professor Ahmed Awadein for inviting me to comment on this interesting case. As we see, there is a left hypotropia in primary position, increasing in adduction, decreasing in abduction. Also, there is a limited elevation, mainly in adduction, normal in abduction. So, the problem or the vertical deviation is mainly in adduction. So, the oblique muscles were to be accused, either the inferior oblique weakness or the superior oblique tightness. Professor Ahmed analyzed the case very well, and I agree totally that the cause of limited elevation in adduction is either inferior oblique injury leading to inferior oblique paralysis, and this is, in my opinion, the most accepted because first of positive head tilt test, A pattern, which is common with inferior oblique palsy, and the most important is the nearly normal forced adduction test, which is not the case in Brown syndrome, in traumatic Brown syndrome, in which the forced adduction test is usually positive and with tight superior oblique tendon. The slight tightness present in this case is mostly due to secondary changes, which occurs mainly in paralytic strabismus, which are contracture of the direct antagonist, overaction of the contralateral synergist, inhibitional palsy of the contralateral antagonist. The direct antagonist of the inferior oblique is the superior oblique. As regards the management of such a case, management in this case should be directed to maximally weaken the superior oblique muscles, because the inferior oblique is totally paralyzed. Professor Ahmed weakened the superior oblique conservatively by doing superior oblique tenotomy with 6 mm suture spacer, and he got some good results as regard the hypotropia, but intorsion is still present. In order to maximally weaken the superior oblique, according to Helveston, is to do superior oblique free tenotomy without spacer. So I recommend to remove the suture and do free tenotomy of the superior oblique. In case If there is a residual hypotropia in adduction after free tenotomy, we can shift to the contralateral superior rectus weakening. Thank you very much.
Good evening and Ramadan Kareem. And thank you, Professor Ahmed Awadein, for sharing this very interesting case. And it's of my pleasure to share the discussion of it. The obvious diagnosis is traumatic inferior oblique palsy, of course, with secondary superior oblique overaction. Most cases of inferior oblique palsy are iatrogenic after inferior oblique weakening procedures, or even after lower lid surgery, especially blepharoplasty. But what the problem in this case? Why it is very interesting? Because the limitation of elevation in adduction only is the distinctive sign of Brown syndrome, and it's not usually present in inferior oblique palsy or in superior oblique overaction. Most cases of inferior oblique palsy will cause secondary superior oblique overaction, A pattern, hypotropia in primary position, and positive head tilt test, but rarely inferior oblique palsy and secondary superior oblique overaction may cause marked limitation elevation in adduction. And rarely inferior oblique palsy can simulate Brown syndrome. Brown syndrome is by far more common, but it's usually accompanied by V pattern, not A pattern, and negative head tilt test. But the most important diagnostic sign in Brown syndrome is the positive force reduction test, which is usually strongly positive. But what to do now? I think one should reoperate on superior oblique again by removing suture spacer and doing full tenotomy of the muscle. Also, something must be done for exo. I advocate left lateral rectus resection 7 mm. This surgery, according to my experience, has a large opportunity for getting an excellent result. But if there was any degree of hypotropia in primary position after surgery, the next step should be right superior rectus resection. I am Samer Hajjo, a strabosmologist from Syria, and this is my opinion and my experience, and thank you for listening.
Good afternoon, dear professors and colleagues. It's my pleasure to have this case with you today in the fifth episode of the EAPOS Ramadan quiz. My name is Sarah Meher, lecturer of ophthalmology, Cairo University. My case is a 24 years old gentleman working as an accountant, presented with headache, eye strain, and intermittent blurry vision with near work, with the letters and numbers running together on the page. He has a free medical history and there is no past ocular history of trauma or surgery. Here is his visual acuity and refraction. He has an uncorrected visual acuity of 1 in both eyes and insignificant refraction both pre and post cycloplegic as shown in the slide. His examination revealed bilaterally normal anterior segment in both eyes, bilaterally normal intraocular pressure of 12 mm mercury in the right eye and 13 mm mercury in the left eye. The pupillary reactions are normal in both eyes with bilaterally normal fondi. Ocular motility examination revealed full ductions and full versions in both eyes. Regarding the muscle balance using alternate prism and cover test, he has just a flick exophoria for distance without correction around 4 prism diopters. However, his near deviation is intermittent exotropia of 20 prism diopters with good control, and he had the same angle of deviation in different directions of gaze. Regarding the sensory functions, the Worth 4-dot test, he has fusion, and he has a near stereo acuity of 120 seconds of arc. His near point of convergence is around 13 centimeters. He has 12 prism diopters of positive fusional versions at near and near normal negative fusional versions at near of 14 prism diopters. Now, what is the diagnosis? What is the cause of the patient's headaches, blurry vision at near, and athenopia, and what are the management options, taking into consideration that the patient refuses wearing glasses? This what will be discussed in our next episode with our dear professors, Dr. Keel Arnoldi, Assistant Professor, Department of Ophthalmology, University at Buffalo, New York, and editor-in-chief of the Journal of Binocular Vision Ocular Motility, and Dr. Rasha Zidain, Assistant Professor, Department of Ophthalmology, Cairo University.